Hi, I am Dr. Nagesh. I am a consultant orthopedic surgeon. My special interest is in complex trauma, complex fracture management, arthroscopy of the knee and shoulder, and arthroplasty, especially knee and hip bracing. Usually, when we think of a rotator cuff injury, first thing we have to understand or rule out is there any impingement here or is there any bursitis. This impingement and bursitis mainly are responsible for the tear in the future. Okay, so usually clinically we assess for the impingement test and then rotator cuff stress test. If there is a pain, then we will diagnose as a rotator cuff injury, and sometimes we take the help of the MRI scan to assess what is the severity of the damage or the tear. Suppose let us say it is a stage before tear happens, that is called tendinosis, that is inflammation and degeneration of the tendon. If it is associated with an impingement syndrome and subacromial bursitis, okay, let us think of that condition as the earliest stage of the degeneration. So, most common thing is rest, usually hot packs or ice packs depending on the patient's comfort, some physiotherapy, ultrasound and IFT, and some exercises, specific exercises will help in improving the situation. If the situation is not improving, usually I prefer to give a local corticosteroid injection to reduce the inflammation in the bursa here. That improves in many situations. Suppose if the acromion is hooked, that is grade 2 and grade 3 acromion, and if it is associated with a bursitis and if the tendon is not torn yet, then the best treatment, if it is not improved with physiotherapy and injection, we have to go for what is called as an arthroscopy, and we have to do subacromial decompression. This is a very simple procedure. Again, it is a daycare procedure wherein what we do is we will completely debride the tissue. Here this is the bursa, here this is the bursa in between the head of the bone and the acromion. We will debride the bursa, and whatever the hooked acromion is there, we will bury it and trim it, and we will give the space for the tendon to move easily. Then there is no chance of tear. So this is earlier to the tear we are detecting and we are improving the condition. In this state the results are good. Suppose the tear has already happened, what happens is the muscle retracts like this. Then what we do is, again we do arthroscopically, we will completely debride this and do subacromial decompression. Then we do arthroscopic suturing of this cut tendon back to this position. Okay, this is one procedure. But all said and done, if this rotator cuff tear is very mild or minimal, the results of arthroscopy are good. Though many surgeons are doing arthroscopically massive tears also, in my personal experience, I feel if the tear is very mild or minor tear, let us say less than 5 mm as an approximate estimate, I do prefer a arthroscopic suturing. Otherwise what I do is I will do a open repair. The results of open repair are very good when the tear is massive, that is more than 1 centimeter and up to 3 centimeter, 4 centimeter retraction. Then we will do a open repair wherein we will take an incision like this along the front of the shoulder. We will go to the part. Okay, sometimes we take the incision like this, we will go to that part, we will expose the muscle and we will repair the tear.